We have the honor today of having Dr. Juan Uribe. Dr. Uribe is the Chief of the Division of Spinal Disorders, Volker Sonntag Chair of Spine Research, and Vice Chairman of Neurosurgery at the Barrow Neurological Institute. Today at the 2021 IWBNC, Dr. Uribe is going to share with us his talk on single position surgery, applications and technical considerations on the prone lateral approach. Please remember to write your questions in the Q&A panel on the bottom of your screen. We will read them to Dr. Uribe after his intervention. Welcome, Dr. Uribe. The screen is all yours.
Thank you. It's an honor to be here, invited for the second time of this great academic activity. So today I'm going to give you a little bit of tour on the single position surgery options, specifically on the prone lateral approach to the spine. Basically going from the side to the spine, but in prone position. So that's basically a variation that we're doing lately for a selected group of patients, as you will see through the lecture. So the first question is always, so why are you doing prone lateral surgery? If lateral surgery has been working good on lateral position, what is the need of, what are the benefits of doing this surgery on prone position? So the answer is this one, simple and straightforward. The big benefit is you save time and you save money. So in other words, is a good proposition for the healthcare that is becoming more expensive day to day. And when you have savings on the healthcare exercise, and time is actually always a really good proposition. And this is like universal, and it's coming from the ancient times. The bigger limitation, as we know, of the humankind is the time. Time is what limits most of what we do. So we always trying to buy time. So if I can do a surgery instead of doing it in 2 hours, in 1 hour, so everybody is going to save. Anesthesia is going to be better. The patient is going to be less exposed to the surgery. Every chance of whatever happens when you do a long surgeries will be diminished. And then you will have more time to decide what you want to do. And at the meantime, obviously, it will be translated in time. So this is the big benefits, which I'm sure that you agree with me that is worthwhile to give them a try. However, it has a very clear advantages and disadvantages. So let's go over the advantages of doing the lateral surgery on the spine in prone position. So first, obviously, the natural position for spine surgery is the prone position. All of us as spine surgeons, we're very familiar placing the patient in prone position. It is very easy to perform decompression of the neural elements, what we usually call laminectomy so far. So it's very easy on the prone position. The orientation for the surgery, for the surgeon, is very good. The orthogonal position in prone is very easy to understand. The lordosis comes with an extra bonus when you put the patients, as we know, in prone position. The lordosis comes automatically. At least we take advantage of the maximum lordosis that we can have in the best position for that. Another feature is if you're using navigation and robotics, definitely the prone position is the friendliest position from robotics and navigation, because the patient tends to be more stable and there is less chances to having problems with inaccuracies of the navigation. And then by gravity, obviously, the retroperitoneal and the peritoneal structures tends to move more anterior, which can help a little bit in terms of decreasing chances of complications. Okay, now let's look at the disadvantages. Well, doing these surgeries is not as comfortable when you are standing. So you have to be sitting and your head has to be bending. So ergonomics is not the best. Breaking the table and have access to the lower level, which usually is L4, L5 on the true lateral transpsoas is hard. And also when you break the table, also moving the ribs cranially so you can access the thoracolumbar area is more complicated. So it's a little more challenging, that part. Also is a little bit of a counterintuitive approach. Obviously, when you do, for example, an A-lift, you do it in supine, is the natural way to go anterior to the spine. If you're doing a lateral surgery, the most intuitive approach is on the lateral position. And if you do a posterior surgery, obviously it's in the posterior, in the prone position. So it's a little bit of intuitive, but the reason that we do it is because it comes with a lot of savings, as we see later on. And then obviously, it's very complicated trying to do a true anterior A-lift in a patient in prone position. You know, obviously we've seen everything nowadays. I'm sure that one of these days we're going to see someone doing an A-lift with the patient in prone position. Let's see. So, so I'm going to show you a little bit of a scientific base of what happened with, especially with the psoas muscle when you put the patient in prone position. So this is actually it's not a published research yet, but I already gathered the data from our institution. So basically what we did is we pick a set of voluntaries, personnel, and we perform MRIs in different positions. We perform MRIs on supine, lateral, prone, lateral with extended legs, lateral with the hip flexion, prone with the hip flexion, and prone with the hip extension. So basically, we try to simulate every possible position to access the spine from lateral, and we look at the vascular structures and the psoas and see how they move. So, and the results were very interesting. So we knew it that the psoas, when you put the patient in prone position, it tends to move posterior. And actually, when you have the patient on lateral position, it tends to be thicker. And I'm going to show you in the next images a little bit. This is one of the participants, and you see how the difference is in different positions. The first picture on the left, this is an MRI with the patient in lateral position with the hip flex. So you're looking here, if you pay attention to the psoas muscles, this is at the L4-5 level, and you compare exactly with the prone with the knees extended, you can tell that the muscle migrates posterior a little bit. So if you compare, the extent of the anterior displacement of the psoas is less over on the prone position, which was very interesting because when you compare prone to supine, you see that the changes are not too much. So actually the muscle behaves very similar between supine and prone position. Obviously, the colon has a little more migration posterior on supine, but as you see here, when you put the patient in prone position, the surgical corridor, which is this one, is actually not in a bad condition, actually helps a lot. And the fact that the muscle migrates a little bit posterior, so the femoral nerve lives inside of the psoas muscle, so it will be by nature a little more posterior. So that one, it may be a favor in terms of the approach. However, when you start doing these surgeries in prone lateral, you will notice that technically is a little more challenging for the surgeon than the lateral surgery itself in the lateral position. And because it's a little bit more complicated, as I'm going to show you later on. So what moving in here, so I want to give you a little bit of I will say take home points, what I learned after doing 200 cases on prone lateral on the prone position. So one is this one. I will call gravity is king. So what you have to be aware is that everything, every structure wants to move anterior. So you have to be careful because when you have the patient in prone, everything will move towards the floor. So you have to be careful because the structures are going to be moving down and you're going to be anterior all the time. And as you know, if you start placing cages anterior, that can be a complication. You can start having problems with the vascular structures. Second, the retractors love to move superficially. So the challenge of this surgery when you have the patient in prone lateral is how can I keep always the retractor posterior and how can I keep it deep? Because the retractor by nature will like to come out and move anterior. So if you understand these two principles, I'm sure that your rate of complications is going to be less because most of the problems, especially cage misplacement, it comes from these two phenomena. So even if you think you're in the right position, you take your x-rays or you're using navigation, whatever system you use, if you don't pay attention, the retractor will start moving anterior to the surgery. And when you start using mallets and put forces on it, the retractor likes to move out. So if you keep your eyes on these two factors, I promise you, your results are going to be better. So from now on, I'm going to show you two good, I would say, two representative cases that I picked from the one that I performed from lateral. And I will take advantage and give you some of the technical nuances and details as we go along these two cases. The first one is a case which I did it 100% using fluoroscopy. And the second one, it was used using navigation and a little bit of fluoroscopy. So you will see the difference of the two techniques, one using only fluoroscopy and the other one using a navigation system, because I recognize that there is some hospitals and areas where access to navigation, which is expensive technology, is not feasible. But it doesn't mean that you cannot do these cases. You just basically do in fluoroscopy how we do it. So the first case is as you see here, is a patient with mild adult spinal deformity. As you see here, he has some mild coronal imbalance and apex of the curve and L4-5 with some discrepancy, minor discrepancy on the spinopelvic parameters. A patient that has lordosis on the high 20s and a pelvic incidence in the high 40s. So it's a patient that obviously needs some lordosis and ideally correct some of these scoliosis. So as a minimal invasive spine surgeon, my own bias is what is the least that I can do to this patient that it can have the best outcome scenarios without compromising the foundation of the spinal deformity correction. So in other words, is what is the smallest surgery that I can do with this woman that I can help her with her pain on the back and the legs, but at the same time, I'm not creating a monster. Let's say I'm not fusing the patient flat or I'm not burning bridges. So in other words, if this patient deformity in the future will continue developing, there is any plan B that I can just go and add more levels without compromising. What I don't want is to make a smaller surgery and then if the patient needs something else in the future, then you have to take everything out and start doing big osteotomies. That is not a good idea. So this patient, as you see here, when we, for example, apply the GAP score, which in my opinion is a little bit more aggressive than the regular Schwab way to manage the spinopelvic parameters, it comes with a moderate disproportion. And when you see here all the numbers, this patient basically is on a need from some lordosis. So this is a little bit of close-up of the x-rays on the patient, as you see here, just on the straightforward x-rays, it's very clear there is an allisthesis on L4, L5. The apex of the curve is in L4, L5. This is a minor deformity. When the patient is standing, there is basically no fractional curve at L5S1, which is in favor to trying to avoid the fusion from the spine to the pelvis. That, as we know, every time we include L5S1, we open in the patient for a different set of potential problems. And on the lateral x-rays, you see that definitely is losing some lordosis. You see it's basically a flat back. So, but what is telling me here, this is actually our somehow mobile spine. So you're looking here at the MRI, obviously L4, L5 is the worst level. There is some focal kyphotic deformity at the L2, L3 level, which I'm going back and show you here. So L2, L3 level is probably the level that is losing most of the lordosis, as you're looking here on the MRI. And then this is a actual view of that. So you saw the L5S1 was not that bad. This is a CT pre-op. Again, you see the allisthesis in 4-5, the absolutely loss of this height at 4-5 and 2-3, the kyphotic focal deformity at 2-3, and the loss of lordosis at 4-5. So in this case, my goal was to trying to fix the coronal deformity, the allisthesis, that is probably the source of the radiculopathies, and try to do the minimal. So I decided that this patient may have the good idea will be L2 to L5, trying to leave L5S1 alone, and obviously a thoracolumbar junction alone. And in the future, something happen, it will be easy to add L5S1 and extend it if it's needed to a thoracolumbar junction, instead of going up front and doing like T10 to iliac or something big. This is the bone density, which I always recommend you have to have a good idea what is the bone quality on these patients. In this case, as you see, is borderline, which is not bad. So the patient qualified for a fusion. So now we go in the technical details of the case. So that you see here, the patient is placing prone in a regular Jackson table. You see here a bunch of taping, and you see here and kind of MacGyvering. So for countries in development, which they don't have too much resources, using here and not doing nothing fancy, I just putting a bunch of foam and tape, and in order to try to have a pivot on the contralateral side of the approach. That way we can lower a little bit the iliac crest, and then we can move a little bit up the T12 and T11 ribs. So that way we have a little bit of corridor, so we can work on that. Every time I do a scoliosis on using MIS lateral approaches on the lateral position of prone, I always like to go from the concave side, because the vector, as you see here, when you go from the concave side, the vector goes to one point. So it makes me go a very small incision. And also, once you try to break the patient, you start correcting the deformity just by the position. So that's the good reason that I like to go from the concave side. And also, usually on the concave side, you have good access for L4, L5. So as you see here, you put the patient in prone position. I want you to show you here these lines that I mark. I like to mark midline incision and two lines at 5 centimeters from the midline. And these two lines, I use it for a couple of reasons. One is every percutaneous screws go from this distance. It doesn't matter who you are, how much you weigh, what color you are. Everybody at 5 centimeters from the midline, you can put pedicle screws on everybody. And trust me, if you do this, you will start saving time. And you make easy for everybody in the OR to understand. So you see, you mark your incision, then on the lateral position, you find your index level, you target. Ideally, I like to target on the posterior third, you know, you divide the vertebrae in, this is half This is the posterior third. I like to target the posterior third. And the reason is because in prone lateral, things tends to go a little bit anterior. By the time you get with your finger into the retroperitoneum in the psoas, you end up pretty much close to the 50-yard line, to the midline on the level. So using here, nothing fancy, you open your incision, you start dilating the abdominal muscles step by step until you see retroperitoneal fat. So the sequence is this: you open your incision on the skin, you see the fat of the subcutaneous tissue, then you find the fascia of the abdominal muscles, then you start dilating one muscle at a time. The reason not to use Bobby to cut, electrocautery to cut the abdominal muscles is to avoid injuring these little nerves that goes in between the internal oblique and the external oblique abdominal muscles that can be the cause of the abdominal pseudo hernias that sometimes we see on lateral surgery. So once you get that and you get into the retroperitoneum, you perform a blunt dissection with your finger, and then you put your first dilator, as using here, trying to find this space at L4, L5. Once you put your dilator, then you, in this case, this was, remember, the level of the olesthesis, which is a little bit more challenging. Using here, I get an angle approach, so I can get into this space. As using here, you find the way your wire get into the space. You do your monitoring, make sure that you're not, you are in front of the lumbar plexus, that the femoral nerve is not compromised. Then once you do that, using here, I'm in a sitting position. The retractor is, so this is superior on the patient. Obviously, the floor is this way. So the retractor, I like, and I prefer a 3-blade retractor. And the reason is because the posterior blade always retracts the femoral nerve and the plexus. And then the 2 lateral blades are keeping the retroperitoneum out. And then there is an opening on the anterior part of the retractor that let me control the slope anterior. In other words, where the anterior longitudinal ligament is. So it gives me a good idea where I am. The retractors that are too much close, what you don't have a good view what is anterior, if for some reason the fluoroscopy changes, then you end up making a big complication and hitting something anterior. So that's one of the big reasons that I like 3 blades retractor. It's a really good configuration for that. So you're looking here, you put your wire, and then you open your retractor, the minimal, and then you start using instruments to prepare the end plates, whatever is your preference, cobs, box cutters, curettes, until you put this in here. In this case, notice that the cage is a little bit more anterior than what I was planning. And the reason is because anterior always likes to go anterior when you're in the prone position. So you have to control that. But then you put your cage, and then you go to the next level, same thing, which is in this level was a little bit easier as using here. Then you go to a third level, which was the level that has that kyphotic deformity. Remember, the L2, L3 was a focal deformity. So in this level, I was very focused on how can I give more lordosis. Again, you find a way to put your wire through it, as you see here. Is a little bit of challenging because the osteophytes, you see how the wire bends. Then in this case, I decided to do a release on the anterior longitudinal ligament, ACR procedure. So we cut the ALL, and then we put a hyperlordotic cage in order to give some lordosis at that level that was needed. So then the next part is once you do the lateral part, then you go posterior right away. Remember that 5 centimeters lines. So that they use it for the placements of the screws, as you see here. Then you put your pedicle screws, and then you pass your rod. And this is kind of the way that the construct looks at the end. And as you see here, it's a good control of the olesthesis. We gain good lordosis. And this is the CT pre-op, if you remember, where there was a significant loss of lordosis. As you see here, it was a discrepancy between supine CT and the regular x-rays, so which was kind of flexible deformity, which is very good for MIS techniques. And then you see the postoperative CT. So definitely it's a really good change in lordosis, level to level. And then also is good in direct decompression. This is the CT postoperative in coronal. You see how the allostasis, actually when these cages, as we know, lateral is great for managing allostasis. You see how just the cage getting in here is actually makes a good correction. And obviously this level that was also bone in bone, you see how with only 8 millimeter height cage, you can have a really good results. And this is the MRI post-op, as you see here. Indirect decompression works very good on this patient. So you're seeing here, good indirect decompression of the central canal. And the most beautiful thing is that we didn't do any disruption of the posterior elements. All the spinous process, laminas, everything is intact. And we did, I would say, a smaller surgery for a big complicated procedure. Using here, this is the final scoliosis images where we get a really good coronal control of the deformity. And second, we provide some lordosis that actually keep the patient on balance. And the best part is that we didn't have to go to L5S1. We didn't have to do any osteotomies, and we didn't have to go to the thoracolumbar junction. As you see here, this is a patient fit in a good condition, which we think that this procedure is going to last for a long time. And then in the event that this patient fail in the future, it's very easily to add more levels proximal or even go and do an A-lift on 5-1, and that's extended. So using here, this is a good example when less is more, and using a prone position, we save a lot of time in terms of positioning and that. So we're going to go on the second case and the last case. So the second case, will take me another 5-10 minutes, so I don't want to take too much time of your attention, because I really big believer that after 40 minutes, our minds get out of control. So I'm going to show you the second case. This is actually a straightforward everyday case. So all of you have this case, someone in your practice. It's a classic patient with L4, L5 stenosis, L4, L5 mobile grade 1 spondylolisthesis, as you will see on the x-rays. And I'm showing in here the axial view, just not for you to look at the foraminal stenosis, at the central canal stenosis. I want you to see it as a lateral spine surgeon. When you are doing a lot of lateral surgeries, the lateral axis surgeon doesn't look only at the spine canal the way that we were trained when we doing only open laminectomy decompressions. So what I'm looking in here is, first, I want to make sure that the patient has a good anatomy for the lateral axis. So first, what is the psoas relation with the vertebral body? Yeah, it is too much anterior, like a Mickey Mouse ears, where it's transitional, and we don't really want to do that cases. Yeah, or is like in this case that is escorting lateral the vertebra, so we actually can have good access to the vertebra and place the interbody. And also, where are the big vessels located? You see here, they're anterior. So this case in here, in terms of access on lateral, is a really good candidate. So you see here, this hyperintensity is in here. This is actually where the plexus lives. So the femoral nerve is going to be here, the obturator nerve, all these structures are going to be here. So it means if we go in front of them, we retract these nerves posteriorly. As long as you retract it for less than 15-20 minutes, the patients will be good. Then the other thing that I look on it, on these patients that are facing lateral surgery is there is any of the predictive factors that tell me that this patient will have a good indirect decompression. The first one is, obviously, if there is any loss of height on the posterior one, because I'm going to put a cage that is going to increase the height and then it's going to do ligamentotaxis, and it's going to open the spinal canal. Second, using here, this, look at the facets, this hyperintensity on the facets, on the T2 sequence, is a really good indicator that this spine is moving, and this will going to respond good to indirect decompression. So this patient has all these characteristics. This is a perfect candidate for lateral transpsoas surgery and indirect decompression. So we decided to do it in prone lateral because we wanted to do in a single position. We don't want to do the lateral and then put the patient in prone and put the screws, or sometimes we do the patient on lateral and we put the screws on lateral position. But as you know, and I'm sure you'll agree with me, putting the pedicle screws on lateral position is not as easy as put the screws in prone position. Especially the inferior screws, that's a torture, you know? And if you haven't done it, when you do it, you will remember me. So this is a good case, which I say, let's do it in prone position, prone lateral. Let's try to get a good indirect decompression, stabilize that level. Using here is a minor movement between flexion and extension at the L4-L5. Again, you see the patient is in prone position. So we're gonna have a little bit of differences in this procedure compared to the first one. First is obviously it's a single level, more simple, but second, we're gonna use navigated techniques. So in this case, as you see here, like everybody else, I mark a midline and 2 lines at 5 centimeters using the fluoroscopy. You know, this technique, I don't do it 100% with navigation. I use some fluoroscopy through the key points, so I have a real live information of what's happening. Because don't forget, navigation, you're taking a CAT scan 15, 20 minutes ago, and you're relying on these images for the rest of the case. So if things move, then you really can have problems. So the only way to have a real-time information is if you keep a fluoroscopy machine close by, and once in a while you take one picture, so it gives me an idea what's happening. So you see here, and then this little marking here is obviously for the marker of the navigation. So you put in here your marker. As you see later on, this is just make sure that your patient is in a perfect AP and lateral position. When we do these cases with navigation, first we place the pedicle screws. And you wanted to know why you're doing first the pedicle screws, and then second, you're doing the interbody. And the answer is very simple. Where you need the navigation more accurate is when you're doing the pedicle screw placement, because the tolerance for failure is very little. So when you're doing lateral, if your navigation is 3-4 millimeters off, it's not gonna happen anything different because this space is too big. But if you are 4 millimeters off placing a pedicle screw, it means like you will be hitting the roots of the dura. So that's why I like to start first with the pedicle screws where the navigation is just right there and more accurate, and then do the second part, the cages. As you see here, first part is placing of the pedicle screws. As you see here, I'm using modular screws. Using here, these screws are loose in the heads. Yeah. Why I'm putting the screws without the heads? The answer is very simple. When I start doing the lateral, I don't want these towers all over in here on the place on the OR that is gonna take and limit my view. So you put the pedicles on pedicle screws in a modular fashion. Using here, I always keep a fluoroscopy machine. I call it as a sentinel machine. I use it only to take once in a while one picture, make sure that things make sense. And then once you put the screws, you go lateral as you see here. And remember this marker that is in here, and that 5 centimeters incision, that 5 centimeter incision has another use for me, as you see in the next video. So you see here, you get access, and then the surgeon on there with the left hand is actually using the 5 centimeters incision to help to navigate the retroperitoneum with your finger. So you're using the incision that you use for the screws as an opportunistic way to help you get through the retroperitoneum, especially on these large patients where your fingers are not long enough to touch the psoas muscle. So using here, I was using this other finger to help me to feel the psoas and make sure that the colon was clean. And then as using here, now with the navigation, I validated, make sure that things are fine. And navigation has a huge role in prone lateral surgery, because the fact that I can see the psoas, as you see on the screen, the fact that I can see the psoas and I know exactly where I'm placing my first dilator, it helps me a lot, because I can pick an entrance on the muscle on the axial views as using here, anterior to the psoas, and that way I have a really good three-dimensional idea what is the spine, as compared to fluoroscopy when you have only two-dimensional view. So using here, I'm placing the first dilator exactly where I think is safe on the anterior third, the entry point on the muscle, but then I put it on the posterior third of the vertebra, following by doing the monitoring. As you see here, I'm showing again one more time the value of the navigation. So then the next part is you keep dilating to the muscle as using here. Using monitoring is very important. You need to make sure that you are in front of the lumbar plexus. So using here on this view, you have on the right the fluoroscopy image, on the center the navigation, on the left the monitoring cameras, and on the left there is this other technology that we use. It's called LES-ray, that help us to reduce radiation exposure. But obviously here we're working with a lot of technology, which for some of you don't have access to this, but this is good to, I want to show you how technology can make your surgeries a little more easier and less complicated. And then using here, I checked with an x-ray, make sure that the place that I choose on the navigation is correct. Then once you get here and you find your entry points, as you see here on this picture, then the rest is the carpentry. So again, for you that get more familiar with the images using here, this is the dilator at the level. You see the screws were placed on the modular fashion, so there is no rods, because I still have the need to be able to do indirect decompression. Check at the reference mark at the 5 centimeter line, and the incisions of the previous screws that as you remember, I also used them as a guide to get into the retroperitoneum. Then you put your retractor as using here. So see that the ergonomics is not the most friendly. You're working sitting as compared to working very comfortable position standing. And then as using here, the next step is the regular carpentry, cups, box cutters, and then using here, checking, make sure the positioning is good. As you see here on the navigation, we're in a really good position. And then now it comes, in this case, I'm preparing the end plate. You see this is a cup. You see how the navigation can help you to see where are you at. And don't forget, I always keep the fluoroscopy as a sentinel. In case that I have a question, I always take one shot once in a while. So obviously it's decreasing a lot my radiation exposure, and this three-dimensional way to see the spine helped me a lot in terms of be there. Now you just keep going. In this case, we're using a, so see, notice that the other surgeon is holding the retractor for me, because these retractors, they like to go superficial. Don't forget what we talked at the beginning. The retractors like to go superficial and anterior, so you have to keep it there pressure. And then you put your cage, as you see here. And then once you put your cage, see, there is no rods. That way I still can do my indirect decompression. Then you go back and you just put the towers of the screws. You see now the towers are there. And then you pass your rod, and this is your final results. So you see here, it's a very straightforward technique. You save a lot of time. In my opinion, is safe and reproducible. However, it is more challenging than doing lateral surgery in lateral position. So if you never done lateral surgery, I recommend you to start with lateral position first, get familiar with the retroperitoneum, timings or retraction of the lumbar plexus so you don't have femoral nerve injuries. And then obviously there is a lot of potential for savings. Again, if you ask me why I'm doing prone lateral, the answer is very simple. I save time and money, and for all of us, time is what matters. You know, most of the people, what you only want to earn in life is time. There's nothing more valuable than time. Time for what? Playing with your family, do more business, go and do sports, who knows? But time is so precious that every time I can see a way that I can save some time, I'm candidate for that. So this is pretty much for that. Obviously, there is a need for prospective trials. If you want to go in details, we published this paper with all these details, as I mentioned today, in Journal of Neurosurgery Focus in last year. So this is a little bit of the reference if you want to have it. One of the good things is this one has a videos and is a free access journal. So all of you guys can go on deep and read if you want to do that. Also, you can follow me. So I routinely place cases and share new challenges and new ideas on LinkedIn, and also in Instagram. And in our institution at the Barrow Neurological Institute, we always have visiting opportunities for international for national surgeons. So we are already full open now that the pandemic is unfortunately much better, at least in the US. And we open now 100% our international visiting program. So just email me, and if you're interested to come and spend some time in here in Phoenix, and we can do these surgeries, and you can see the real story behind the prone lateral, all the laterals, and what we're doing here. And you also can be helping us with our publications. So thanks very much, and it was a pleasure to have this time with you.
Thank you, Dr. Uribe, on behalf of CIEN and the IWBNC for your very, very interesting and enlightening lecture. Now we have some questions from the audience. The first question is the following. For those surgeons in developing countries who may not have access to a Jackson table, do you think it is possible to do prone surgery on a typical OR table? If so, what recommendations do you think would be necessary, or what kind of things do you think could be helpful for this kind of surgery?
Yeah, absolutely. I think the Jackson table is not mandatory, so you can build a similar situation like the Jackson table. I would say you put two large bumps, one on the chest, one on the iliac area. You can create a similar figure that you do on the Jackson table. You just make to make sure that the bumps are high and long enough so the abdominal contents get free, because what you don't want is put too much pressure into the intra-abdominal contents, because a lot of things are going to happen. First, you will have the colon and the peritoneal structures are going to be more in front of you. You don't want that. And second, the venous pressure will be increased and you will have more bleeds. So you don't want that. So I would say definitely you can do it. You just need two big bumps that you put it over your standard table, one on the chest, one on the iliac. And then as long as the abdomen is free, I think you can definitely easily do it. You just make sure that you have access to the fluoroscopy, AP and lateral.
Thank you. A second question is in relationship with the ALL release. First is, what recommendations or technical tips do you have around doing ALL releases? And second, in relationship with the prone approach, does it change your technique for ALL release, and in which way?
Yeah, so I'm glad that they had this question, because ALL release, the ACR, as we call that procedure, is actually the maximal expression, I would say, sophistication of the lateral axis. And we recommend you to do ALL releases when you've done a lot of lateral cases, because the technique is basically you dissect behind the big vessels, you pass a little dissector, and then you cut the ligament. And that maneuver, I mean, as you know, the complication can be catastrophic. You know, you have the big vessels on the front. And when you're working with incision this size, working 15, 16 centimeter deep, your plan B when you have a vascular injury is very poor. So in other words, is you have to have a full control. However, we like to do it because it's a very efficient way to provide lordosis, you know, and the ALL release with a hyperlordotic cage competes with pedicle subtraction osteotomy, as we know, is also a very complicated procedure. So that's why we believe on the ALL release. But I'm glad that this question coming here, because this is the most sophisticated step on lateral surgery, and we want you to do it once you become very familiar. And you know, we have lectures of half an hour, 44 minutes, only dedicated to the anterior column release. So we have multiple papers published on that. If you go in PubMed or even in Google and put anterior column release, I'm sure that you will find our papers on that, and you can read more in detail. But definitely, it's a great question.
Thank you. A relatively related question is the following. In which cases do you decide to use a cage with screws, a lateral cage with screws, versus a standalone cage and posterior pedicle screws?
My God, these questions are very good. So that's why it's so important to leave time for questions. So yeah, it's a great question. So first thing, I'm gonna tell you why you can put cages with no screws from lateral. And there is the answer is on the biomechanics of the spine. So when you do a lateral access to the spine, you leave the anterior longitudinal ligament intact, you leave the posterior longitudinal ligament intact, you leave the interspinal ligament intact, the facet ligament, the yellow ligament, everything is intact. You only open a little window of the annulus lateral and you go through and through. So that's why you can put a cage on lateral with absolutely no screws. When you're doing, for example, an A-leaf and you cut the anterior longitudinal ligament to put your cage, if you leave that cage alone, it will drop into the abdomen. If you do a T-leaf and you take the whole facet and you put the cage, you cannot walk away without putting screws because it's a very unstable. Those procedures are destabilizing procedure. The lateral transpsoas at itself is a procedure that is not destabilizing. That's why you can put this cages with the screws. So now without the screws. Now the question is why in some cases I put screws. Okay, so you saw in that case where I did the ACR, the anterior column release. In that cases, you always have to put a screw. And the screws on the cage are not to give any stability. They're placed to prevent the migration of the cage anterior, because when you cut the anterior longitudinal ligament, these cages can go anterior and you can have the big migration complication. That's the only situations when I put plates or I use screws. Doing a regular lateral case where you leave all the ligaments intact and you put a plate and screws, that's actually biomechanically, you're not doing too much. Actually, sometimes you create a stress riser between the screw and the cage, and you can create these coronal fractures through that. So as long as the cage passed the midline and is sitting in both diaphyses, I'm telling you, chances of that cage migration are very little.
Thank you. Another related question is, in which cases would you consider standalone lateral cages?
Yeah, so standalone lateral cages are for cases where it has to have a couple of check marks. First, your bone quality has to be good. You don't want to do a cage standalone in a patient with a lot of osteoporosis, because don't forget, the biggest enemy of the lateral access, the lateral spine surgeon, is subsidence, because you lose your indirect decompression. So first, you have to have a good bone. Second, if the patient has a lot of instability, like a spondylolisthesis, you don't want to do a standalone in that cases. You need the pedicle screws to hold and stabilize the spine, yeah? So my indication for standalone cases are in these two spectrums, or the very old patients where you know that a laminectomy can be very morbid. For example, patients with heart conditions, anticoagulated, because I know that when I do a standalone 1 or 2 levels, to me is a 25, 30-minute surgery. Patient go home same day. Even more complicated, believe it or not, than a laminectomy. The other spectrum is young patients. There are very few that had a black disc disease, or they have a degenerative spine that have been trying multiple options, not surgically, for years, and they beg you for a fusion. Those patients actually are very good candidates for a standalone fusions. That's my 2 candidates.
Thank you. With respect to subsidence, there are 2 big tendencies with respect to how you choose your cage. Some advocate for not so tall of a cage, and some do advocate to have more pressure on the interspace with the cage in order to gain more lordosis. What are your insights with respect to cage subsidence avoidance in lateral surgery?
Yeah, that's a good question. So first part is you have to start with good bone. You see, I was showing bone densities on that. If you don't have a good bone quality, your incidence of subsidence is going to go super high. Second, you like to undersize your cages. The problem is most of the surgeons doing interbody fusions, they're previous T-leafers. They've been doing T-leaf. And in T-leaf, the goal is the bigger you put the cages, the better. And if you have subsidence, it doesn't matter because you're doing a direct decompression. So in lateral, for example, what I like to do is I measure the height of the disc pre-op. If the height is almost 4 or 5 millimeters, I know with a 10 millimeter cage, it will do the trick because I'm giving more than 100% this height gain. So in summary is taller cages provide good setup for subsidence because you put a lot of pressure on the end plates, and then they look great in the OR when the patient is under anesthesia, sedated, and you put the cages. But these cages putting too much pressure on the end plates, then you will see in 4, 5, 6 weeks the patient comes with a lot of subsidence, then you lose all your job. So if you look, when I look at my own cases numbers, 90% of the cases are probably 8 millimeter height, 7 or 8% are 10 millimeter height. And I can say, I count with my hands how many 12 millimeter cases or higher I put in my life. So in other words, 8 or 10 cages height, millimeters will do very good with, I would say, decent rate of subsidence.
Thank you. The following is a technical question from Dr. Odira from Kenya. What recommendations do you have with respect to the management of lateral disc osteophytes for the approach?
Yeah, so lateral disc osteophytes, actually, they're very easy to handle on lateral surgery. So when they are ipsilateral, what I do is I don't fight them. You know, you don't want to go and start biting them because one is osteophytes are a cortical bone that if you use them, but the cages to sit, they will help you with the subsidence. And usually there is a way that you can get through it. That usually that osteophytes are a very poor attempt of the body to have a fusion. So usually what you do is you put the retractor, you break them a little bit with a cob or with an osteotome, you get into a disc space, and then you keep your surgery dilating and using all the instruments, and then you go through the osteophyte with no problem. When they are contralateral, it's actually easier. You just go, once you get into this space, you just bleed them out with a cob, and then you keep dilating. But what you don't want is to take them out, because 2 things happen. One is you want that cortical bone for your cages, as I mentioned before, but also you're gonna start a source of bleed. So you don't want one more source of bleed into the psoas that can create a psoas hematoma post-op.
Thank you. The following is also a technical question. What do you think the role of the endoscope or exoscope is in this type of surgery, and do you have experience with its use?
Yeah, I've been trying them. I think it's actually a very sophisticated question. I've been trying exoscopes clinically and also in the lab. There are very nice technologies. The problem that I have with the exoscope is that sometimes the entry of the camera limits my manipulation of the instruments, but definitely it's a really good alternative. In prone lateral is very interesting because it will help with the ergonomics. We're trying right now a very small camera that is mounted in one of the blades of the retractor. It's called Vision. And that camera, we're just working on the lab right now, trying to make it work. But I think on the prone lateral is a really good alternative. The problem is we need to train our eyes to work in a two-dimensional way. The exoscope has the three-dimensional feasibility. However, the entrance of the image is a little bit on your way. But definitely, I will say, it's a really good question. 5, 6, 10 years, probably this surgery is going to be performed, a lot of them with this kind of help. You know, now that cameras and that technology is getting much, much better. So you can work with small incisions and more precise. And you don't need to bend your head and get this awkward position, especially in prone lateral.
Thank you. The next question is as follows. As prone surgery is probably the evolution with respect to surgical positioning of lateral surgery, do you think there's a role for the possibility of doing an anti-Solas approach from the prone position?
Yeah, and I've been, you know, it's so interesting when you go to social media, some people say like, I did an O-leaf, you know, oblique lateral in the prone position. I've been, you know, I work a lot in our labs on cadavers, and we do a lot of, it's very hard to go 100% pre-psoas with the patient in prone position. You can make a variation of the position, make a little bit oblique, and try to dock more anterior. But to be honest, the prone lateral position, probably your best case scenarios go trans-psoas, but you know, you get anterior, in the anterior part of the muscle, and you can have a really good deal. Which is interesting is someone going to do an A-leaf on prone position, which I don't know, you know, we see everything in life, but wanted to know if someone with, who knows, mirror cameras do it. We've seen everything, you know. One of my partners in here actually, believe it or not, is doing a lateral in supine position. So in some cases, he does 5-1 A-leaf, and then for 4-5, because you don't want to move all the vessels, you know, 5-1 A-leaf, usually on O-leaf, you have to deal with the vessels a lot. So in supine position, while the patient has the incision open for the A-leaf, he goes through the psoas and do the 4-5 in supine. So you see everything in here. So it's very interesting. Who knows? But as far as I know, oblique on the prone position is a little bit challenging. You don't want to hit the vessels, you know, for no reason.
With respect to neurophysiological monitoring, do you have any specific recommendations, or do you think you should change anything with respect to monitoring in the prone position? Yeah,
and monitoring is unfortunately one of the big limitations for, you know, through the world for adapting lateral trans-psoas surgery. You know, the oblique, the pre-psoas approach to the spine is the response of surgeons all over the world not having access to a good monitoring system. Because if you don't have directionality, it's very hard to know where is the lumbar plexus with relation to your retractor. You know, like what we call generic monitoring systems, they can identify the femoral nerve, but when you pull your retractor, you don't know if that nerve is in the front or in the back. And that one created a lot of complications early on lateral trans-psoas surgeons that didn't have directionality. To me, if you don't have a good directionality, I mean, like an EMG that you know that you're stimulating anterior, posterior, then you must better find a way to do a pre-psoas or something, because it's so critical, the identification of the lumbar plexus with a good monitoring system, especially in 4-5, that is better for you to do a T-leaf or something else. I know that the company that has the EMG with directionality now is pretty much almost everywhere in the world, and there is more access. But definitely, to me, trans-psoas without a good monitoring system is a big limitation.
The next question I find quite interesting for all of us who are interested in medical education, and is as follows. As you know, lateral surgery is not that new as a technique right now, but it is new for a lot of surgeons, both young and old. What recommendations, in your experience as an MIS surgeon, do you think, how do the steps, how does that curve, how should you initiate your way into lateral surgery? With what kind of procedures, what kind of interspaces, what kind of positions? How would you recommend those surgeons who are starting their way into lateral surgery to begin their experience and then move on forward towards more complex surgeries?
Yeah. So the first part of the answer is the lateral surgery is a very technical procedure, and unfortunately, compared, for example, to TLIF or PLIF, TLIF or PLIF, you can do whatever you want, you can move the nerves, and rarely you have problems. The lateral surgery is more sophisticated in terms of technically, you need to have a very clear steps and you have to follow. So the first thing is, I would say, you're trying to learn lateral surgery. My first recommendation, if you're a fully trained surgeon and you're practicing, you better spend some time, go and see someone doing it for real. That's very important. You go and see someone doing lateral that has a good experience, because you have an idea how they flow. For example, let's see this. When I do a lateral, for example, 4-5, that is the most demanding level. If you want to keep your numbers of femoral nerve injuries under 1-2%, for example, when I put the retractor, once I put the retractor and the cage is into the vertebra, my timing is 6-7 minutes. So you have to be able to create a standardized step-by-step sequence where your X-ray tech knows exactly what is he doing, your scrub tech knows what is the next instrument. Everybody, this is following like so you first is, you see someone that is doing it, do it in a cadaver ideally, try to do it in cadavers, and third, create a very nice standardized way. Don't do like, we as a surgeons, we're very arrogant, and all of us, we have, this is my way, I do it this way. That's one of the biggest problems that we have when we train in spine surgeons on lateral. There is a standard technique, obviously you want to look at papers we've been publishing to the last 10-15 years on lateral, where we define 6 or 7 steps. And if you attach to those steps, I promise you, your outcomes are very good. Trying to stay away from, I prefer to do this, I like this, because I think, just go where we have been showing through the time that it actually works. And it's 6-7 steps. And this is what I do with my fellows and residents in here. They come, some of them just come that they've been doing a lot of laterals. And after their fellowship year, first thing that they say is like, I can't believe that I was doing lateral surgeries. Now I understand how much is that. And what we do is we just get one set of steps and we repeat them. And after you do it 20-30 times, you master them. And then it's amazing how the outcomes becomes.
Thank you. The last question is a two-tiered question. First, what tips and tricks do you recommend to avoid damaging intra-abdominal structures? And the second, in relation to that, how do you manage them when you identify them in the OR, especially vascular injuries?
Yeah. So first, I'm going to start that actually is very simple, which is, I love it, is you don't need any technologies to avoid what we call catastrophic injuries, which is vascular injuries or bowel injuries. I'm going to tell you something. I've been doing around 2,000 lateral surgeries on my lifespan career as a spine surgeon, and I've been lucky. I never have a bowel injury or vascular injury. It doesn't mean that, I have a surgery in the next 10 minutes that may have my first bowel injury. But I can tell you it's a combination of two things. One is every surgery I treated like my very first surgery. I never take shortcuts. I never say that I've done it too many, it's so easy. So second is every time you dilate to the retroperitoneum, first thing that you do, you feel the quadratus lumbaris, that is the posterior wall of the retroperitoneum, lateral or prone, and you ride over the quadratus lumbaris until you feel the transverse process of the psoas. And then you know that is on the top of your finger, on the back of your finger, there is no bowels, there is nothing. And then you start moving your finger anterior, you feel the psoas, you feel the fibers of the psoas. And then as long as your finger is there, you start dilating toward your finger. I promise you, you will never have a bowel injury. And then vascular injuries, believe it or not, they happen because the surgeon loses control of the case. It's very easily when you have the patient on lateral, the patient rotates on you. And what you were thinking was the mid part of the vertebra, now is the anterior part. And that's how you get the vascular injury. So you have to be checking all the time, the patient didn't move, that you're totally orthogonal to the patient, that you're not aiming anterior. The first thing that a surgeon do when he's doing lateral is going anterior. That's like a natural way that the mind works. You put someone with a curved instrument and you tell them to put it deep on the spine and use it. First thing that they do, they move back and they go anterior. So you have to, as long as you are aware of that, chances to have bowel injuries or vascular injury are very little, you know. And we publish a paper and we checked 14,000 cases through the Solas Society, and the incidence of vascular injury and bowel injury is less than 1%. So I always say every time that complication happens, surgeon lose control of the case.
Thank you. Thank you very much. So on behalf of CIEN and the IWBNC, again, we thank you very kindly for your lecture and your experience and all your comments. This has been a wonderful experience for all of us, and we are very grateful and honored for your participation in the 2021 IWBNC. For the audience, keep in mind this lecture will be available for free and 24 hours a day on our website through a direct link. Right now, you can have access to Dr. Berger's lecture, The Role of Brain Mapping for Glioma Resection, Results with Nearly 2,000 Awake Mapping Cases. The link is available on the chat box in your Zoom screen. Thank you kindly. Dr. Uribe, thank you again.
Okay, thank you, guys.